Morning, everyone. First of all, thanks Narendra Vaidya sir for inviting me to give a talk. So I've got a tough topic on my hand. So we all know as surgeons in India especially, most of our patients come late and we always find out of 5 or 10 normal knee replacements, you will have the worst of the worst deformities, and the toughest cases come our way. It's always like that, in India especially. So, what are the challenges in dealing with deformed knees? One, it's because of we've got biplanar deformities. It can be ligament laxity because of deformities. And as a surgeon, for me, I'm a cruciate retaining surgeon who was trained for ligament balancing and moved on to measured resection with Navio. So it was a big dilemma for me to adopt technology. I was not sure whether can I trust Navio. So it was a big thinking for me. Should I, as Dr. Cabot was saying in my initial days, should I trust Navio, go ahead with surgeries, or go ahead with my instinct and let's do it. So I've developed this approach for all my knee replacements. The one good thing about the robotic knee replacement with Navio is the workflow is the same. Whether it's uni, whether it's a normal knee replacement, or whether it's a complex primary surgeries, the workflow is the same. The surgeon, I always believe that the skill of robotics is for precision, accuracy, but the skill to get it right is because of the surgeon. Surgeon is on top of the instrument. So it's not about the robotics as such. Surgeon has got the perfect control of what he's doing. So, and I'm a conservative surgeon. So from a cruciate retaining with ligament balancing, I'm a very conservative surgeon. So I adopt the same thing on my planning stage. For me, the registration is the key. I take out all osteophytes, spend more time on the planning stage. I take out all osteophytes before my registration, because that's the key. Because once your registration is done, once your planning is done, and the final ligament balancing, if you remove your osteophytes, it might change what your results are, what you planned for. You won't be getting that. So soft tissue releases only if required post my measured resection. That's what what I've learned through this my journey with robotics, where before I was doing a lot of soft tissue releases. Now just for the to put my peg holes or for the tibial cut, I just release some soft tissue. That's all. That's my usual workflow. So this is the first case. So she's sorry for the video. She's a 60-year-old lady with a windswipe deformity. One in valgus, one is varus. And this is the x-rays for her. So this is a typical, windswipe deformity. So I started on the valgus side. And this is the x-ray for me. See the laxity on table. And this is my stress views. And I rely on the Z retractor for my stress views. For common even unis, or maybe unis, I might rely on my just a valgus stress view. But for all my TKs, I use my Z retractor for it because I find it's very reliable. And if it's obese patients, I don't know how much stress to give. But with the Z retractor, if you get your retractor in a good position, I think the stress is the same, equal throughout. So I rely on my Z retractor. So in this, we are doing a valgus knee thrust. You see the medial is so tight and the lateral is loose. So this is where, I spend more time on my planning. And here the basics of any surgery comes into picture in arthroplasty, where I don't, put a lot of external rotation. I always want my implant in a little bit of external rotation, 3 degrees. I don't think so. I've put any implants in at 0 or internal rotation. No, maybe for some cases yes, but I've not done it till now. And when you see my planning, you can see my preoperative was 12 degree valgus, postoperative was 6 degree valgus. And you can see in my extension and flexion, I've kept my extension tight in the lateral side. Medial, it is loose. So it's all because I can always resect bone later. I don't want to take out more bone. I always believe that I can always resect. Even with Navio, you can always go refine, get to 1 mm, 2 mm bone anytime you want. So I spend a lot of time on planning, as I believe in. So this is the stress view post-op, that is with implants on. You can see the curve. It's bang on, straight. There's no medial lateral opening, and it's flat. It's less than, I think, 1 mm. It's opening less than 1 mm. So this is the picture what we want even if it's a primary, complex primary surgery also. And this is my post-op during surgery. So absolutely, I couldn't move a bit also of any of the knee. So I always tell, okay, she can go play football. It was football. So these are the result what I get on table with Navio, and it's every time it is the same. And this is my post-op X-ray. And coming to the next slide, so this is a routine varus valgus stress views. And this is my planning. I always want to keep it tight, as I told you. I plan for tight. And I usually don't overcorrect the deformity. I always keep, if it's with severe deformities, I always keep them a bit varus or keep them a bit valgus, because I feel that if you get your ligament balancing right, if you get a measured resection, you get a rectangular gap on inflection, extension, right, I think the implant won't fail. And if you see, my component position is varus 3Ds, and in the tibial component is 4 degrees varus. It's acceptable. And that's what I believe in. So this is my post-op stress views. It's bang on. What I've aligned was pre-op aligned was 12 degree varus and 6 degree varus. So this is the post-op stress view. And this is the X-ray of the patient. So she is walking on 10th post-op day without any support, with you can see her turn with absolute balance. And this is the difference what we get with robotics. And I would not, in my 12 years of practice, I would not expect this with my regular knee replacements. I've never got this. So this is the most exciting part of doing arthroplasty with Navio or with robotics. So where what you plan for, what you achieved is absolutely the same. So this is another patient, a farmer with severe varus deformities of the knee. So he came to me this way. So this is the X-ray. There's a deformity on the medial side. There is a bone loss on that side. It's a fixed deformity. It was not correctable. So this is my stress views, and this is my planning. So these were the few cases initially when I've done about 50 cases with Navio, and these are the few cases where I took it as a challenge, and I believed in myself, and I've got it. So the pre-op, there was 22 degree varus, and post-op, we've got it to 9 degree varus. So if you can see your tibial component, you can see I've not, on the lateral side is 13 mm I've cut, and resection is still too high. That's what it shows. But I keep medial side tight because I can always go do ligament releases if I want to. And so you can see in this I've put at external rotation 5 degrees. There are a few cases where I do external rotation. And so this is my planning, and this is what I got in post-operatively after my implants. So from a pre-op alignment to 22 degrees to 9 degree varus. So, and my gap balance is absolutely dead on. So this is my post-op X-rays. So, and this is on the right side, similar deformity. This is stress views, and this is my planning. You can see I kept my medial compartment tight on extension. And this is the post-op X-rays. And this is about 3 weeks post surgery, and he's back to actually farming within a month. So that's one. This is the one thing which tells surgeons like us that you got to believe in technology also. So which I would have not done in my regular hands. There is something extra edge that the technology gives to us. So this is another case where this lady came to me with varus deformity of her knees, severe varus. And this is the X-ray where the lateral ligament was totally lax. And this was my first few cases, very few cases, and I was very worried about this case. So I had my backup while doing such surgeries, constraint implants, always there. This is my stress views. You can see how lax the lateral compartment is. And this is my, planning, where I put this 6-degree external rotation and this. And this is my final view from a preoperative alignment of 17-degree varus to 9-degree varus, and medial lateral is bang on. This is my post-op X-rays. So got a very good alignment. She is a very happy lady with straight, and I'm going to do her on the next week, the other knee, and she's walking like this on the first day without any support. So what's the take-home message? What I would say, young surgeons like us who's adopting to technology is, for me, planning is the key and surgeon is the boss. The skill of any surgery is the surgeon, and that's not taken away from us with this system. So where you are the boss and you plan the surgery, and robot just executes it. That's where precision comes in. That's where accuracy comes in. And I believe it's my assistant in the OR, who's safe and trustworthy, because when you see how it only cuts what are the deformed bone, it doesn't cut anything else, and it's always accurate and precise every time we do it. And I believe that robotic empowers the surgeon to be even better. So that's what it's given me, that extra edge over the conventional surgeries what I used to do before. So I see that in my patients' recovery. And before I used to give my patients a walker to walk around, but they just refuse a walker. They say first day they use a walker. Once they're comfortable with the knees, they start walking by themselves. So without any stick, they go back home. Stake climbing, that like Dr. Rutra said, was 3 days. And they're up and about doing everything. And, within 2 weeks, I've got one patient who's gone back to work. So that's something which thing. So for me, is always the planning is the key. And as we all, using technology in and out of at home, everywhere. Now you have Alexa everywhere at home. So you get everything when you just got to command Alexa. So it's actually better than your wife, actually. So she's always there for you. So I believe in adopting technology, being in tune with what's happening in surrounding areas. I think we as a nation, who are, everywhere, everyone looks us as an IT, capital or empowerment. I think we need to, stay tuned what's happening, adopt technology, and it's definitely good not only for us. The ultimate is the benefit goes to the patients. And I would say surgeon is always a surgeon, but this helps us to be a better surgeon.